YouTube.
Give brief introduction of Dr. Bruno, and then Dr. Bruno will present.
So,
Hi, Jiple.
Dear friends, we are going to start the meeting today for the massive anatomical rotator cuff tears.
Hi, Jiple.
Just a minute. Dear friends, we are going to start the meeting today for the massive. Ek minute.
Mute the YouTube.
Yes, I have already muted the YouTube. The thing is that I lost my own Zoom window. Okay. So we have the today's speaker is Dr. Bruno Tousse. He is a very famous shoulder surgeon who has visited India many times. He has got phenomenal work in shoulder instability and rotator cuff tear management. He is basically from ASGI Shoulder Institute, and he has got many research papers on the rotator cuff as well as the shoulder instability. So he is a very reputed, renowned shoulder surgeon amongst the shoulder fraternity. Now I'll request Dr. Bruno to start the program. We have the moderators for today's meeting, Dr. Rajkumar Amravati, Umesh Jadhav, Mihir Patel, and Sanjay Trivedi. So I think we have Dr. Sanjay Trivedi and Rajkumar Amravati here. Dr. Mihir will join us in some time. And Dr. Nicholas Antao, who is a coordinator of this meeting. And we have panelists, Dr. Vivek Pandey will be joining us sometime, Dr. Nilesh Kamath, Abhay Narvekar, Jiten Maheshwari. Jiten was there, I think. Jiten Maheshwari.
He's there.
Dr. Kronal Shah, Rajiv, Raman, Gaurav Gupta, and Dr. Prathamesh Jain and Jaya Prasad. So all these moderators will, panelists will speak on and they discuss on every subject of today's meeting. And we have 3 talks today by Bruno, one on anatomical consideration in rotator cuff tear, then single or row versus double row, what's best, and third is a massive rotator cuff. What is the policy? Repair, reconstruct, replace, or tendon transfer? So Bruno, will request you to start with your first talk. I'll hand over the complete program to two moderators, Dr. Rajkumar Amravati and Dr. Sanjay Trivedi.
Thank you, Roshan. You can start. I am very sorry for the.
Okay, not at all, Bruno. But it's a pleasure to have you with the Arthroscopy Academy. Without wasting much time, I will ask you to start your presentation.
Unmute.
Yeah.
You can hear me, Bruno?
Sir, unmute Dr. Bruno.
Yes,
Roshan,
yes,
sir.
yes, unmuted. Dr. Bruno? I think problem is from his laptop.
Make me co-host.
Bruno, can you unmute yourself from the laptop, your own laptop?
Sir, make me co-host.
Okay. Now you earn me again?
Yes, we hear you.
Yeah, we can hear you.
And we request you to please start your presentation. And we are all eagerly waiting to hear from the master. Welcome to the program.
Okay, it's okay. You earn me well?
Yes.
Okay, we start with communication. It's an anatomical consideration in rotator cuff repair. My disclosure. There is a very long story of cuff repair because at the beginning it was by open procedure, and it's very difficult for Guy Gassman and Gene Wolf to demonstrate that it's so easy to do the repair by arthroscopic technique. Because arthroscopic is less invasive technique because there is no deltoid violation, and you make better exploration and certainly better release by arthroscopy than open technique. In parallel, the progress of the arthroscopic technique, some very famous authors like Eiji Itoi and Hiro Sugaya describes the anatomy and the footprint, the anatomy of the footprint of the cuff very well. It's Itoi work about the footprint of supra and infraspinatus. You see the ad from Hiro Sugaya about the different footprint of the supraspinatus and infraspinatus over the grid tuberosity. It's very important to know there is two different layers in infraspinatus, because the deep layer, it's very important to reattach onto the grid tuberosity to have the best healing as possible and to have the best result as possible. But for the cuff tear, it's very important to have a good assessment of the quality of the muscle and you need to have a good assessment of the size of the tear. You need to check the delamination of the tendon. You need to check also the muscle atrophy. You see here the different stage of muscle atrophy and the fatty infiltration. It's to know exactly the fatty infiltration, because if you have very bad muscle, it's not very good idea to reattach it onto the grid tuberosity, because the result is poor, definitively poor. And the natural story of the asymptomatic rotator cuff tear shows there is a progression of the size of the tear, and it's the big thing to repair the cuff tear, because now we know the tear is growing step by step every time. For the arthroscopic management of the cuff tear, you have a different access to the cuff with the scope and instrument. Basically, the soft point is in this position like this. It's the beginning of the arthroscopy repair, because you can check everything everywhere. And after, you have a different portal to improve the assessment of the cuff tear and to improve the repair, because you can introduce your instruments or the implant by everywhere, and it's a good improvement for that. Anteriorly, you can have different portal for anterior approach of the shoulder. After, you need to have a good assessment of the shape of the cuff tear, and C shape is the most frequent cuff tear. You see here, it's easy to repair if you don't have a retraction of the tendon, because you pull it and you remove and you fix the tear in the right position. You see for the L-shape tear, the retraction is not in the same direction of the fiber, but it's oblique to the fiber, and you need to manage differently the muscle fiber to can reduce the tendon in the right position as well. For posterior, you see here, you can manage the tendon posteriorly to be safe and to have the best repair as possible. For U-shape or V-shape, you need to manage like this is not possible, but you move the anterior and the posterior flap, you can reattach the cuff and the tendon in the right position. But you need to have a good release when you do the cuff repair, and especially the anterior part, because you have the capsule and supraspinatus is here, and you have the coracohumeral ligament, and he locked the muscle into very close to the coracoid, and you need to release it to have a good mobilization of the tendon, and you can repair as well. You see the release from the coracoid. You need to go around the coracoid to release the tendon as well. And after that, you can manage very easily the tendon. Here you see the anterior release. Inferiorly, it's a subscapularis tendon, and you cut and you release the coracoid here like this, because coracohumeral ligament in the middle layer of rotator interval, and you need to open the rotator interval you see here, and you finish to cut the last part of the coracohumeral ligament, and you detach it from the coracoid, and you can be sure your tendon of supraspinatus is free as well, and you can mobilize very easily in this. And you see after you can manage and you can move the tendon. It's a subscapularis tendon, and you can move the tendon very well. You see here. There is different disease of the tendon, and you can have partial tear, and you can have partial tear for articular side or subacromial side. There is different classification. It's very important to check the deep layer and the superficial layer, because sometimes the superficial layer is practically intact and the deep layer is totally damaged and sometimes retract regarding the superficial layer. And you need to release the two layers together and move the deep layer in the right position as well. You can make transtendinous cuff repair, but you have a dog hair sometimes is not the best way. I prefer follow the technique from Castagna, and I complete the tear and I reattach the two layers in the right position. For the subscapularis, is a little bit different, because the subscapularis is one part of the biceps groove, and you have the superficial layer create one part of the biceps groove, and you need respect the superficial layer and deep layer of the subscapularis. Inferior part of subscapularis is only with the muscle. There is no tendon. The tendon is the upper part, but not in the lower part of the muscle. We describe with the French Arthroscopic Society some different one new classification of the subscap. In the type 1, there is just a fraying of the biceps groove, and in the type 2, you have a split in the biceps groove. You can see very well here, and you can go with the hook into the split. In the type 3 is a partial cuff subscapularis tear. You have just deep layer detachment, but the superficial layer is in continuity with the biceps groove. And with the for the type 4, you have full detachment of the subscapularis tendon, and you have just connection with the upper part of the subscapularis and supraspinatus. It's a comma sign. It's a very good sign and very strong attach. You can reattach at the upper part of the biceps groove to reattach very well the tendon of supraspinatus and subscapularis. You see here the big the comma sign, because here is the supra, and you have a lesion of the subscapularis here, full thickness of subscapularis. You can reattach with the two anchor, one inferior, one posterior, and you can make double row technique if you want for the subscap. In the past, there is some theories. Basically, a rotator cuff tear cannot be operated with a stiffness because with open procedure, it was difficult to have a good management of the stiffness in postoperative period. Now with arthroscopy is totally different. Normally you need to have a good range of motion, and the risk of secondary stiffness is increased by the open procedure. With you see the classification of Isakos for the stiffness shoulder, frozen shoulder, and secondary stiff shoulder. You see the meta-analysis, and the stiffness modifies repair of the rotator cuff because it increases pain and restricts the range of motion, especially forward flexion, forward elevation, and external rotation. With the arthroscopy technique, it's definitively not a problem because you can operate stiff shoulder, because in the same time you can make arthrolysis, especially you can cut the inferior capsule and you release perfectly the superior capsule, and after that you have a good mobilization of the tendon and you can have a good range of motion of your shoulder. The coracoacromial arch must be conserved as well as possible. It was described from very long time by Codman, because it's important to have a good coracoacromial arch, because if you destroy totally this arch, you can have a superior and anterior dislocation of the shoulder. Acromioplasty is not always necessary during the cuff repair. You see some different study of full thickness repair, and you see the outcome is good, and you have a very good aspect. The problem of the suprascapular nerve in massive cuff tear is interesting too. Albrighton described there is impingement of the nerve, entrapment of the nerve with the retraction of the tendon. You can see, because when the tendon is retracted, the nerve is entrapped into the coracoid notch. But its anatomical study is not really through, and J.P. Warner and especially Boykin describe, if you reduce the muscle in the right position, you reduce the nerve in the right position too, and you decrease the entrapment of the nerve. It's one part of the second topic is the double row must be better than single row. On the cadaver, in the lab, definitively it's better, but in the clinic is not so evident, and very frequently there is no difference between the result after double row or single row technique. I mean, it's necessary to have a good technique, and you use this technique every time. Single row technique is definitively cheaper because you use less implant than in double row technique. But double row technique make a low profile of repair, and probably it could be in a good option to restore the footprint as well. There is different approach of the difference of double row technique, but you see for multi-center randomized controlled trial comparing single row with double row fixation in arthroscopic rotator cuff repair, there is no difference. Thank you for your attention for this, for the first one, and now you can go directly to the second one.
Bruno will have some questions on this. I think.
Okay.
Yeah, we'll take some questions and then we'll go on second one. So I'll request moderators Dr. Sanjay Trivedi and Dr. Rajkumar Amravati to start discussion. We have Dr. Jiten Maheshwari with us, Nicholas Antao, Jaya Prasad, Dr. Raghuveer.
Good evening to all professors and dear friends. Now the first presentation is open for discussion.
Yes, absolutely.
You can ask Professor Bruno any questions that you have.
So, Dr. Tussom, it was interesting to note your French classification of the subscapularis tear, and it is
interesting because the subscapularis is not the same tendon as the supra or infraspinatus, because subscapularis anatomy is different, because the deep layer is attached, is fully attached to the less tuberosity, but the superficial layer is not attached on the less tuberosity, but is attached over the onto the biceps groove and was connected with the supraspinatus fiber in the superficial layer of rotator interval. And the most frequent tear of the subscapularis is a partial tear, because it's only detachment of the deep layer. And there is different level. You can is partial detachment of the less tuberosity. It's full detachment. But in partial detachment, you have sometimes the split of the anterior wall of the biceps groove, and if you check the biceps groove, you can understand very well what type of subscapularis tear you have. And it's very important when you check into the joint with the scope to go to the biceps groove and to search to pass the rope into the anterior wall. And you can detach in two parts the deep layer of the subscap. And in this case, I mean, it's better to repair it. And probably, because I am French, you make biceps tenodesis too. But I mean, if the biceps is okay, without inflammation or whatever, and without fraying, you can conserve the biceps in the groove. And if you have any doubt, you can just cut it. Biceps anatomy, it's good enough.
Bruno, I have a question regarding the capture, the release, what you have spoken about, the going up to the base of the coracoid and then releasing it. So do you always release the coracohumeral ligament in all kind of your anterior releases, or it is a select few cases associated with only stiffness?
In stiffness, always, because I mean, it's participate to the stiffness. And I mean, it's important to cut the coracohumeral ligament. But for medial size cuff tear, I mean, it's good to release the upper part of the capsule and the coracohumeral ligament, because you decrease the tension onto the repair, and you make the repair easier, because you can mobilize very easily the tendon. But for the small tear, I mean, it's not always necessary to cut the coracohumeral ligament.
Okay. Secondly, do you always do the bicep tenotomy or tenodesis whenever you have a bicep exposed, or any other test you like to do before touching the biceps? Like the moment the tear is beyond biceps, do you check for the biceps instability inside the groove, or you always do a
Yes.
tenotomy or tenodesis?
I mean, it's important to check every time the biceps stability and to check there is to research fraying or inflammation of the biceps. If the biceps is okay without fraying, without inflammation, and is stable into the groove, I mean, you can conserve the biceps. If the biceps is exposed with instability or with instability, I prefer to make a biceps tenotomy or tenodesis.
Okay. Rajkumar?
Roshan.
Professor, you can hear me?
Yeah.
Roshan?
Yeah, Dr. Antao, yes, Dr. Antao is
Bruno?
Yes, Nicholas.
Bonjour. Bonjour. Very good presentation. When do you do or when do you advocate extra-articular as well as intra-articular release?
Yeah, because he,
I mean, the most important is intra-articular release, because you don't do any every time intra-articular release. But extra-articular release is practically always did, because you prepare the supraacromial space, and you can to check everywhere the muscle fiber, and every time you release extra-articularly. But intra-articularly, I mean, sometimes you don't make enough to release. And I mean, it's important to check it.
Professor, I have a question for you. Can I ask? Okay. I understand your work in shoulder is phenomenal, and we thank you for that. My one simple and basic question for you would be, what is the function of coracoacromial ligament? What is its function?
The function is it close the space, and the arch is very important, because arch is very strong posteriorly because it's only bone, but anteriorly is a ligament, is the CA ligament from coracoid to acromion. And if you destroy and if you resect this ligament, you can create some damage, and especially the humeral head can go up and anteriorly, because you don't stop it, you don't stop the movement with the arch. And I mean, if you have a subscapularis tear, irreparable subscapularis tear, you must be very, very safe with the anterior part of the arch, because it's a good thing for the stability of the shoulder.
Okay, so we, in all understanding that you are saying is, it is a stabilizer for the, one of the important stabilizers for the acromion as well as the shoulder as well.
Yes.
So that is what you would like to say. Does it also help in, relieving the pain that the patient has when you release? Find a lot of pain generators around the coracoacromial ligament. Does it help in pain management?
Yes, in this case, you need to remove the bursa, and you can detach the ligament from the acromion. But I mean, it's very important to don't resect the ligament, because if you resect the ligament, you lost the elasticity and the strongness of the anterior part of the arch.
Thank you, Professor. Are there any questions from the panelists or the faculty?
We should go on next talk.
Okay, Roshan.
Yeah. Bye.
Professor, you can include your second talk, please. We can go for the second talk.
Yeah, yes, I go. You see?
No, we can't see. Sandeep, can you help?
Okay. I need to I'm sorry. Up.
You open your presentation, then press on the Zoom green button.
Yes. It works like this?
You have to open your presentation.
Okay.
Yeah.
It's good?
Yeah, it's good.
Perfect. And the second one is a massive retractor cuff tear repair, reconstruct, replace, and transfer. My disclosure, some words about massive cuff tear. For Gerber is 2 or 3 tendons tear, and for Cofield is more than 5 centimeter cuff tear. But it's not only geometry, it's also tendon quality and quality of reducibility of the tear. There is a different option. You can make only debridement. You can introduce a spacer. You can just do bicepsotomy or EC joint resection. You can make only suprascapular nerve release if you need. And you can make a complete or partial repair, but it's not always possible. You have some different tendon transfer, latissimus dorsi for the posterior superior defect, but pectoralis for anterior superior defect. But now there is also latissimus dorsi for anterior superior defect, and trapezius transfer for the posterior defect. Superior capsular repair, arthrodesis is sometimes the last option on reverse shoulder arthroplasty, especially for elderly. What is a good indication? You need have a question regarding the age, because elderly is not treated as than active patient or young patient. You need to have a good assessment of the range of motion, the aspect of pseudo-paralytic shoulder, and the quality of the tendon. You have already seen in the previous topic. Clinical assessment, especially for the lag sign test, for test infraspinatus and teres minor. The Hornblower sign is very important to check to be sure you have a good function. Fatty infiltration, okay, is a different indication. Age is crucial to decide, because for elderly, there is no big deal, because you have 3 options. If you have after medical treatment, if you have good range of motion, only painful, you can continue to treat the pain, and sometimes you have a good result. You can have a painless shoulder but pseudo-paralytic shoulder, and you can have both. For the pain relief, you can have a rehab and corticoid injection. For the pseudo-paralytic shoulder, if you can have any result after the rehabilitation, for the elder people, I mean, the best way is a reverse prosthesis, because you can restore a range of motion for muscle forces. And there is very good for the patient, because the patient is very happy with this type of techniques. When the massive cuff tear is irreparable because the muscle is bad with the fatty infiltration, and tendon resorption and muscle atrophy. I mean, sometimes the surgical arthroscopic debridement without repair, sometimes with biceps tenotomy, could be good enough. But you can sometimes, like described by Steve Burkhardt, partial repair with the suspension bridge technique, restores the infraspinatus and subscapularis. You remain with the supraspinatus there, and it works not too bad, but in time, for a long time, the result is not always perfect. You can make a margin convergence because you make a partial repair, and you can restore good aspect, and you move the humeral head down. I mean, it's always better to for the follow-up to can restore to can repair the cuff there, because it's definitively better after time. If you make only acromioplasty or partial repair, you lost the good result after time. Biceps tenotomy was promoted by Pascal Boileau, and I mean for specific cases, it's a very good option for massive cuff tear, because you can restore very well, like with decompression, you can restore very well the function of the shoulder. You can see different technique. Bioabsorbable spacer, like a balloon, it's a good option on Senekovic and collaborators describe very well result after a very long time of follow-up. It's difficult to understand very well because there is a bioabsorbable spacer. After 2 years, there is nothing into the space, but there is a good space between acromion and humeral head. You see the different the technique trick for the balloon, and you see the result described by Agnes Kirchner. It works not too bad, but it's a very expensive technique. Another technique is a superior capsular reconstruction described by Miata. You use the fascia lata, or you can use a dermal graft, and you fix onto the glenoid side, and you fix it with great tuberosity. Anteriorly, and you need to have a good subscapularis, and you can reattach the graft to the subscapularis and infraspinatus to restore the good space between acromion and humeral head. And there is a very good result after that. You see the exclusion criteria described by Miata, and you see the different techniques, like tricks, and you see the cadaver aspect of the repair with the capsular superior repair. And the result is good because you can restore the range of motion, you decrease the pain, but the problem is very sometimes the strength, because you don't restore the muscle strength as well after this technique. If the massive cuff tear is very painful, and you can have some assessment about entrapment of the suprascapular nerve, you can release it, you decrease the pain, you don't modify the functional aspect of the shoulder, because with the suprascapular nerve release, you don't modify the range of motion of the strength of the shoulder. You have already seen that. Sometimes EC joint is very aggressive for the humeral, the tendon of the cuff and the humeral head, with the inferior osteophyte of the clavicle, and to decrease the space between EC joint and the glenoid side, and it's important to resect the EC joint, especially the posterior osteophyte, to be sure to restore good range of motion and decrease the pain. Age is very important to select the patient for the muscle transfer and superior capsular repair. Superior capsular repair could be used for young people if you cannot make a muscle transfer, and before to imagine to do a reverse prosthesis. For the latissimus dorsi transfer, you need to have a irreparable massive cuff tear with a fatty infiltration and tendon retraction, but you need to have a good range of motion, because it's a key point of the good result after this technique. You see schematically the technique of this procedure. It's necessary to detach latissimus dorsi from the biceps groove here. You stay with teres major in the right position, and you pass the tendon posteriorly over the top. There is a big discussion with Jean Cany about the fixation of the latissimus dorsi. Now, I mean, you use flat tendon. Is not necessary to make a tube with a tendon, because you risk have some damage and rupture of at the junction of tendon and muscle. The result is relatively good, described by the open procedure by Christian Gerber, and Mark Tauber makes the same result with a technique from Resch, with a good result. Here, I just would like to speak about using of the latissimus dorsi for anterior cuff tear, especially subscapularis irreparable tear. And you can see, you can use the latissimus dorsi for repair the subscapularis tear, because the direction of the tendon is the same as the subscapularis, and you have certainly better effect than you use pec major, because the pec major has not the same direction as the subscapularis muscle. Thank you for your attention.
Thank you, Dr. Bruno, for that wonderful talk on massive cuff tears and management strategy. Do we have any question? Dr. Rajkumar as well as Dr. Sanjay Trivedi. We have Dr. Abhay Narvekar with us. All the panelists.
Bruno?
Bruno?
Yes, sir.
Rajkumar, can I ask?
Yes, sir, please, sir.
Bruno, do you have a particular age group that you decide about the tendon transfer, or is just does it give pain relief, or does it give also a good amount of function?
I mean, for young people, it's interesting to use a muscle transfer, because you stabilize the humeral head, and I think you decrease the risk of aggravation with time. if you make just acromioplasty, I mean, it's good for middle age or old elder people, because you have with time aggravation of the lesion, and probably you go slowly to the reverse prosthesis. In my end, I prefer use reverse prosthesis after 65 to be safe for the follow-up of the reverse prosthesis.
Remember when I visited Philip, who is the tendon transfer master. Yeah, he and I did a couple of tendon transfers after that. In slightly, one was a case of, which I strongly remember, was a failed case of dislocation, where I did the Latarjet in front and then I put the latissimus dorsi behind. But then the function was, pain was really, stability was there, but function did not come, which was not there. What is your take on that?
I don't understand very well. He used latissimus dorsi transfer for instability? No.
No. I did for instability. I did the Latarjet.
Yes.
Right, because it was a fail.
Okay, I understand.
Rotator cuff, yeah, rotator cuff big defect also, for which I transferred the latissimus dorsi.
I mean, you can use latissimus dorsi transfer, but the problem is of this transfer is you lost strength. You cannot restore, especially for hard worker. It's impossible to have a patient with the same job after the surgery, because it's a muscle transfer and you lost two steps of strength every time. And especially because you transfer one muscle to restore two muscle tear, supraspinatus and infraspinatus, and you use only one muscle. In this condition, Bassam El Hassan proposed to transfer the lower part of trapezius and latissimus dorsi together to restore all two muscle with two muscle. But I mean, it's a big surgery and you lost a little bit strength finally. And I mean, if you have, you cannot restore a big force, big strength for the hard worker. It's okay to have good range of motion, acceptable of strength, but you cannot restore normal strength, especially for hard worker. And in this condition, there is one place for acromioplasty, especially if your patient is more than 50.
Gaurav?
Thank you.
Yes.
Yes, Bruno. Yes.
Go ahead and ask a question.
That was an excellent presentation on massive tears. Now, couple of things wanted to know. One is your indications for suprascapular nerve release, and exactly what percentage of your cuff repairs do you do a suprascapular release. The second is about the balloon. You showed us one, it's something very new for us, and you showed us one article where they have done a 3-year follow-up. So any long-term results with the balloon, and what has your experience been with the balloon?
My experience with the balloon is not so nice. It's very short experience because in France, before the price of the balloon is very high and it's very difficult to propose to the patient. It's one of big problem, and it's like acromioplasty, because you just make a spacer between the acromion and humeral head. It's bioabsorbable spacer. After two years, you have nothing, just fibrosis between the two parts. But with a different study, it works not too bad. I mean, it's one option, but if you don't have money enough, or it's not available in your country, I mean, acromioplasty, it's good enough and makes the same result after time. For the suprascapular nerve release, I mean, there is important to do if you have a big pain and you need to check with EMG. And if you cannot repair the muscle, you cannot modify the entrapment of the nerve. And in this case, you need to cut the the ligament of the coracoid notch to release the nerve. And after that, you decrease the pain and the patient is well.
So it's essentially a pain relief that you are using when it is an irreparable tear, or do you do it even in the tears that you repair?
Because if you can repair the tear, you move the nerve in the right position when you pull the supraspinatus. It was described by Boykin with J.P. Warner. I mean, it's the best way, but you cannot repair always the cuff. And if you cannot repair the cuff, you can need release the nerve to be good enough.
Thank you.
Just a supplement question, Bruno. Do we need to do any EMG study before we decide to release the nerve in irreparable cuff tear, or you just go by the pain symptoms?
I prefer have a better assessment with EMG, but it's not necessary to do it. If you have big pain with irreparable cuff tear, you can make acromioplasty and nerve release in the same time. Very frequently, you need to combine acromioplasty, bicep tenotomy, nerve release together during the same procedure if you have any doubt.
Yes, Jaya Prasad. Go ahead and ask your question.
Dr. Bruno, this is a question regarding the patients with the rotator cuff with the frozen shoulder. So how you approach these patients, the single stage release with the rotator cuff repair or double stage, like first stage as a release of frozen shoulder and the going for the rotator cuff repair?
With the frozen shoulder on massive cuff tear?
Yeah.
Yes. I mean, you need to separate definitively frozen shoulder and pseudoparalytic shoulder, because pseudoparalytic, you have a good range, passive range of motion. With the frozen shoulder, you don't have it. In this case, you need to decide to make arthrolysis. You need to cut the inferior capsule on the coracohumeral and you release the coracoid. And in this case, I mean, it's interesting, especially if the patient is painful, you release the nerve in the same time. But you cannot always repair the cuff tear. You can make partial cuff tear, repair, but not always, unfortunately.
Okay, any other question to Dr. Bruno? Bruno, I think you completed your double row, single row talk in the first talk itself. Am I right?
Yes, absolutely.
So what is your preference for the rotator cuff repair, and what is the anatomical consideration you will give during surgery or before surgery to plan it as a double row or single row repair? Do you decide it is single row, double row during the surgery or before the surgery, and how you convince the patient?
It's a big question, but it's a very interesting question. I mean, it's interesting to try to check it before the surgery, during the exploration, especially with the MRI, because if you have a big delamination, especially with the with the retraction greater from the deep layer. I mean, in this case, it's a good option to make a double row repair because you can stabilize differently and separately deep layer and superficial layer. If you don't have delamination at very important delamination, I mean, it's not necessary to use always double row. After, it's a technique. If you have this technique definitively easily in your hand, you can use double row repair every time. But to answer at your question, I mean, if you have no good indication for double row on the MRI, during the procedure, you check definitively if you need or not double row or single row technique. I mean, the best thing is the delamination of the tendon. If you have big delamination and two layers definitively separated, I mean, it's more interesting to use double row technique. But double row technique is definitively more expensive technique, and you can pass with suture, transosseous suture with the specially device. You can use that if you have two layers there.
Yeah. Any other question to Dr. Bruno before we break?
Yeah, Dr. Bruno, can I ask you a question?
Yes, please.
I understand delaminated cuff tears are a little different animal to treat. Is there any particular way that you take your suture through the delaminated tears? Do you take it separately or in one suture only? And I know you got your paper on a different way of doing a lasso loop.
Yes. I mean, lasso loop is not always the best option because you create you increase the gap between the two layer because you have the not space into between the two layers. For me, the best way, if you need to move separately the two layer, I mean, you need to pass the suture separately into the two layers to be safe, to reduce the two layer in the right position. And in this case, you can use just a single suture to do that. It's not necessary to use different suture, one for the deep layer, one for the superficial layer. With the same suture, you pass through the two layers, but separately, differently, to be safe to reduce the two layer in the right position with your suture.
Okay.
Thank you, Professor. Are there any questions?
I don't think so.
Sanjay?
Yes. Sanjay, we have any question now?
No, I think we are fine.
You're fine. So let me thank Dr. Bruno for his wonderful presentation, his commitment towards the Arthroscopy Academy and delivering two lectures today on a difficult topic of anatomical consideration and massive rotator cuff strategies. So thank you, Bruno. I think I will go off live and then we can have an informal discussion if some